Hi, good afternoon, and welcome everyone. My name is Margaret McLean. I am the current chair of the Policy Council for Children and Families, and I'm also a mother to a medically complex and disabled child. Today, we would like to share with you our biennial report and recommendations for improving services for children with disabilities. The email that was sent to your office has a link to the full report, and you can also find the full report on the Texas HHSC website on the Policy Council page. In a second, I'll start sharing my slides, but I also want to let you know that if you have any questions as we go along, please type them in the chat box so we can answer them at the end. And then I'm also going to ask just through the presentation, if you're not speaking, to mute your microphone and turn off your camera. Okay, so with that, I'm going to share my screen. And we're going to get started. So the recommendations in this report are the members' own opinions and were developed over 2 years ago with input from stakeholders. The objectives for today are very straightforward. I'll briefly review the policy areas, then we'll have council members discuss specific recommendations. The picture you see on the right is a picture of my daughter and I, Olivia, doing a sunrise hike in Canyonlands National Park this summer. Despite her smiling demeanor, she faces daily challenges to live and is dependent upon our family to meet her needs to lead a full, integrated life in our community. Families like mine can attest that as we carry our children both figuratively and literally on our backs, we carry their burdens day to day, and our days start before sunrise and don't end at sunset. Our job advocating and caring for them never ends, and it truly takes a village to raise them. The recommendations set forth in this report are ones the Council feels will continue to advance the care of our children and their families so they can lead full, happy, productive, and meaningful lives. The choices you make during the 87th legislative session will affect whether the child and their family has a positive or negative trajectory. The choices you make will have far-reaching impacts, so I ask you today to carefully consider our recommendations because disability is nonpartisan, non-discriminatory, and cuts across the lines of political parties, income, race, religion, and culture. Today, we'll be covering several broad topics, which include support and expansion of medical transition care clinics, access to Medicaid, ensuring children grow up in families and not institutions, ensuring access to promoting independence waiver, expansion of crisis intervention, early childhood intervention and respite services, disaster and emergency preparedness, planning and communication to ensure continued access to vital services during not only natural disasters, but pandemic and other large-scale events, changes to the MDCP waiver, and then expanding telemedicine. I'll be presenting the first recommendation, which is medical transition clinics. This is a young lady named Christy. Before establishing care at the transition clinic in Houston, Christy was in and out of the hospital at least twice a year for an average stay of 9 days per visit. After establishing care with Dr. Cynthia Peacock and her team of experts in 2012, I'm happy to report that Christy has only been hospitalized twice. Medical transition clinics are essential in bridging the gap between pediatric and adult healthcare system. Whereas the pediatric medical model is family-centric, the adult model is patient-centric and requires autonomous patient input and decision-making, and often lacks many of the interdisciplinary resources found in pediatric healthcare. Adult healthcare systems are not structured to adequately address the medical complexity and costly needs of patients with special healthcare needs. An adult healthcare system is often fragmented and lacks the medical expertise, psychosocial support, and care coordination needed to support the myriad of medical, nursing, mental, dental, and physical needs to ensure continued well-being and aging of this population. There is currently a lack of a sufficient payment model to support multidisciplinary medical care and coordination of services for these adolescents as they transition into adulthood. There is currently only one medical transition clinic in Texas, which is the Transition Clinic at Baylor College of Medicine in Houston under the direction of Dr. Cynthia Peacock. and it only serves a very restricted geographic area in close proximity to the clinic. The Policy Council is asking for continued financial support of the transition clinic in Houston and development of a funding mechanism or mechanisms to create additional medical transition clinics throughout Texas. We are asking you to continue the use of district funding until it is no longer available and develop a startup funding source for additional transition clinics. There are approximately 1.1 million children in Texas who have special healthcare needs and require specialized medical care with multiple specialists. As their population grows, they will funnel into the adult healthcare realm without adequate support and will place further strain on our systems. The ideal scenario would be to develop these clinics in conjunction with or in addition to existing pediatric complex care clinics. There are two main funding mechanisms we are proposing. First, transition district funding to manage care with goals aligned through a direct payment model, such as the Missouri Medicaid Access to Physician Services, or MAPS program. A second method would be to create a capacity building pool similar to the North Carolina 1115 waiver pool. More information about both of these programs can be found in the report on page 10 and in the footnote on that page. In addition to these methods of funding, any pilot program developed could also include alternative payment model strategies tied to quality outcomes. In pursuit to develop medical transition clinics, we recommend that any transition clinics established have in-house shared service coordination models with health plans to provide better health outcomes. This would include face-to-face visits with health plan service coordinators to provide better coordinated care, weekly case conferences to identify barriers to patient care, the inclusion of coordination with other health plans on coordination of benefits and alignment and networks, follow up with specialty physicians and other providers within the same clinic to complete prior authorizations in a timely and efficient manner. And then one of the most important parts is to serve as a resource for any other training needed for additional clinics across Texas, including coverage of benefits, transitioning of members aging out, and then finally, as always, monitoring member outcomes. I'll conclude my portion with highlighting Tyler, who is also a young adult who received services at Baylor Medical Transition Clinic in Houston. And now I'll turn it over to Dr. Christine Murphy.
Thank you, Ms. McLean. Today, I'd like to talk about building provider capacity for training for adult transition clinics. Currently, in medical education across the board, training for complex medical conditions is generally an elective, and students don't tend to get a lot of dedicated exposure to this group. And so we really aren't doing a great job of training our future medical professionals, but in addition, we have a dearth of training in our adult clinicians who are already boots on the ground, and we have to build capacity for both of these areas. Our first recommendation, again, would be to ensure continued funding for the only transition clinic. Dr. Peacock's clinic trains not only medical students, but also our resident physicians. She takes social work students, nursing students. I believe she's also going to be taking dental students soon. And so she's offering an amazing one-on-one education for really expansion of complex care across the state. And as well, any additional transition clinics that we have would offer additional training for medical professionals. Additionally, to expand current capacity, we're recommending that telemedicine consultative services continue to be covered at the current reimbursement rate beyond the COVID-19 pandemic. Telemedicine has become really just a valued treasure, speaking as a physician, and even from patient family standpoints. It reduces wait times, which can help reduce complications, and also reduces the burden of transportation and time out of work costs as well. Next slide. The additional recommendations would be to increase capacity to train providers already in practice. We're recommending the development of two programs that have both been used within child psychiatry. The first of which is a Project ECHO program, but this would be to be specific for pediatric to adult care transitions. You can find more information about Project ECHO, but basically it was formed to allow dissemination of knowledge from academic centers where most of our specialists live and work to rural area providers who typically will see more patients than our academic centers are able to do. Doing this would incorporate continued medical education for both adult and pediatric care providers for complex conditions in a virtual context, and would establish a mentoring forum for providers interested in establishing such relationships. Next slide. We're also recommending that we establish a CPAN-like network for complex care access centers. This has been done in psychiatry as a way for, again, our community physicians and clinicians to access resources that aren't otherwise available. In doing so, we could help with assessment and treatment of medical illnesses, as well as identifying community resources for those impacted by complex medical conditions. The CPAN-like network would also provide information to adult providers for childhood onset chronic illnesses, areas that they typically don't receive much, if any, training in. These services would be provided within a real-time setting and would be requested by a phone call made to a main network hotline during regular clinic hours. Next slide. Staff would typically include a network coordinator to help answer basic questions and triage phone calls, as well as social work specialists to help out with resource identification and access to programs, and clinicians to provide medical guidance as needed. Our final recommendation would be to increase capacity to train providers in training. Currently, we have a dearth of internal medicine, pediatric combined residency programs across the nation, and really there's not very many even within the state. This program, the residency program training, does the best job at providing a really solid core in both pediatrics and internal medicine adult kind of conditions, and are really the place where most of our adults with complex conditions would be safest transitioning to. We're recommending increased funding to teaching hospitals to provide more training positions or to develop new programs where none currently exists. And additionally, I would recommend that that family medicine residency programs who are interested in establishing competencies specifically for congenital and childhood onset chronic conditions be granted special funding to expand their programs as well. This is Ellie. She's a young adult that's currently transitioning to the Baylor Transition Medicine Clinic in Houston.
Hi, my name is Lisa Brody, and I am the current Vice Chair for the Policy Council for Children and Families. I am a speech language pathologist, and I have a 19-year-old daughter with Down syndrome, who you just saw on the screen. She began seeing Dr. Peacock in the Baylor Transition Medicine Clinic this last fall, and it's been an asset thus far. So thank you for being here today. We know that Texas spends far less than other states in assistance, particularly the amount that it spends helping people with special needs. So we would like to make recommendations that would improve access to Medicaid insurance for children with disabilities. And first, we would recommend that by reducing the MDCP interest list. That's one of Texas Medicaid waiver programs, medically dependent children's program. Reduce the list by allowing children who have SSI and meet nursing facility level of care to receive medically dependent children program waiver services with no wait. And that wait is currently up to 5 years. Other waiver programs are upwards to 12, perhaps 15 years. Would also recommend funding of MDCP waiver services for the approximately 575 children who do not have SSI or Medicaid and are currently waiting for critical medical and long-term supports for their children. The next recommendation to reduce the interest list to provide access to Medicaid would be to align the Texas Home Living Waiver's financial eligibility requirements with other Texas home and community-based service waivers so that children can access lower tiered waivers in lieu of a more comprehensive waiver. And also remove the requirement that children with related conditions have an IQ below 75. Slide. Thank you. We'd also recommend applying the Family Opportunity Act's family income limit of 300% of the federal poverty level to the Texas Medicaid Buy-in for Children program and improve outreach so that more families can contribute to the cost of their children's care. Currently, we believe that the outreach needs to be increased as many families are unaware of this. And then also Texas has capped the eligibility at only 150% or less of the federal poverty level. We're also making a recommendation to institute a Tax Equity Fiscal Responsibility Act, TEFRA option for children who meet an institutional level of care to prevent placement in a facility and without using household income as an eligibility criterion. These children are children with special healthcare needs that can be safely cared for at home and could be more cost effective. Thank you very much. This is Nicholas, a young person who moved from a nursing facility after 20 years back home with the support of a Texas Medicaid waiver.
Hello, this is Elizabeth Tucker. Can you hear me?
We can hear you, Ms. Tucker.
Great. This is the story of Nicholas is the story that I wanted to start off with. My name is Elizabeth Tucker, and I'm a member of the Policy Council for Children and Families. I represent a children's advocacy group. And I wanted to tell you the story about Nicholas so that you could have a face and a name to understand the recommendations that we've made in this section of the report. This part of the report is around ensuring that children with disabilities grow up in well-supported families. And you can find the more detailed background and the reason for the recommendations on pages 32 to 38 of the report. Nicholas was born 21 years ago with multiple disabilities and very significantly medically complex conditions. His mother was very, very young at the time. And when he was born, there were very few options that could support her to raise her medically fragile child at home. In fact, there were almost there were no options available should she choose for another family to raise Nicholas and to share in his care. And so she had to make the decision to place Nicholas in a nursing facility 5 hours from her home. Nicholas lived in that facility from the time he left the neonatal intensive care unit at the age of 5 months. When he was an infant, he went into a nursing home and lived there until he was 20 years old. With the support of a Medicaid waiver program, the Home and Community Services Waiver, and the Promoting Independence initiatives of the state of Texas, he was able to leave the nursing facility at the ripe old age of 20 and move back home with his mother. She was able to get supports and services into the home, including a split level converter that would allow for his room to be heated because he was not able to moderate his temperature, and the rest of the house, if they kept it at the temperature that he needed, would boil. It also allowed for private duty nursing to be provided to him on a regular basis. Nicholas uses a ventilator to breathe, and it allowed for some home modifications to be made so that he could shower, and it allowed for also personal care with dressing, bathing, and eating. So Nicholas's life has changed dramatically as a result of the work that has been done over the years and the work that we are proposing the legislature continue to fund and to really look at as the House and the Senate develops their budget. The Texas legislature has made a very historical commitment dating back to the 1990s and again in 2001 to make sure that Texans with disabilities live in the community instead of in facilities. The Texas legislature also, along with HHSC, has a position that the legislature and the state needs to support those families so that children can either live at home or in a family that has been specifically recruited for that child and paid through one of these Medicaid waiver programs. So our recommendations in this section are few, but they're incredibly important. The first recommendation is we're asking the legislature to fully fund the Promoting Independence transition. So those are waivers that help children leave facilities, including nursing facilities, intermediate care facilities, and facilities that are licensed by the Department of Family and Protective Services, and diversion waivers. Those are waivers that keep kids from ever having to go into a facility to get care. We're asking that the legislature provide that funding so that children can live at home and with their families or with another family that can care for them and share in their care with their parents. The next recommendation is we're asking the legislature to provide direction and funding through an appropriations rider for the Health and Human Services Commission to amend one of our Medicaid waivers, the Medically Dependent Children's Program waiver, which Nicholas definitely qualifies for. It's a waiver for children who would otherwise have to live in a nursing facility. What we're asking the legislature to do is to provide the legislative direction and funding to create a reserved capacity for children who are in crisis and are at imminent risk of nursing facility admission. So this is done in other waivers like the Home and Community Services waiver so that children never have to go in to then get out. But for the Medically Dependent Children's Program, in order for a child to get one of these Promoting Independence waivers, they have to go into the facility for a minimum of 30 days or partial time if they're very medically complex. So we're asking the legislature for some help, especially in the time of COVID when it's very risky for a child to go into a facility. The third recommendation is we're asking the legislature to provide direction and funding through a rider for HHSC to amend their lowest cost waiver, the Texas Home Living Waiver, and by creating a set aside number of targeted waivers for children who are graduating high school. The worst thing that can happen to a family is their child can be well supported up until the age of 22. And then all of a sudden at the age of 22, school stops and they end up staying at home with nothing to do and no support to get a job or no support to be part of their community and to continue to be fully included. And so this is a strategy that some other states have taken, and we think it's a good one, and we recommend that the legislature consider this. The final one is increasing funding to support a 10% reduction of Medicaid waiver interest lists. I know earlier you heard that the state has long interest lists for these Medicaid waivers, these waivers that support children to grow up in families as opposed to in facilities. And so we saw very little movement over the last legislative session on both the waiver interest list and promoting independence. And we're asking the legislature really consider funding the request that's been made by HHSC to make sure that children receive the care that they need and care that is the most cost effective. And so I just wanted to end this part of the presentation by trying to paint the picture of Nicholas again in your mind. There are a lot of other children like Nicholas who need your support to ensure that they grow up in families. They need to be able to have a parent that puts them to bed at night, comforts them in the middle of the night if they wake up scared, greets them in the morning, and is there when they're sick and unhappy, and to share their lives. So I just wanted you all to know that the work that you do is incredibly important, and we need your help to make sure that it's continued. Thank you.
Hi, good afternoon. My name is Lori Patlan, and I am a family representative for the Policy Council for Children and Family. For families and children. I will be speaking of our next recommendation, which has two goals included. First goal being improve access to mental health, trauma-informed care, and crisis services for children with disabilities to ensure children are supported to live in families in lieu of costly long-term institutions. Can everyone hear me?
Yes, we can hear you.
Okay, perfect. All right, so our first recommendation would be to develop and fund child-focused.
Lori, we can hear you.
Okay, perfect. Our first recommendation would be to develop and fund child-focused, small, community-based, emergency, short-term, out-of-home respite options for children and families who are in crisis. And these services must include adequate time to assess the child, development of a plan for appropriate supports for the child to return home or move to another family-based alternative, including additional respite and direct support. Thirdly, supports in the respite setting to care for children with complex behavioral support needs, including additional staff if needed. Continuing is continue funding of the Texas START programs in Tarrant County and El Paso, and increase the amount of funds to each site to allow expansion to additional counties. Current START coordinators should be funded to serve as mentors to coordinators in the newly added counties. Critical services for this population of children include in-home therapeutic coaching of families, coordination of START services and clinical services. Create a funding mechanism for the services above, including emergency short-term out-of-home respite, assessment and facilitator services within the Texas Medicaid waivers, as well as the Medicaid state plan and general revenue. Assign a level of need 6 in the home and community-based services waiver to children with complex support needs, leaving long-term facilities such as a lengthy state hospital admission, Department of Family and Protective Services facilities, nursing facilities, and intensive care facilities for individuals with intellectual disabilities for the first year of their transition. And so this is the summation of goal 1 for this recommendation. I will go ahead and pass it over to Mary Klentzman, who will continue with goal 2. Thank you.
Hello, this is a picture of my 32-year-old son, Jonathan, with his brothers at one of his brother's weddings. Jonathan has quadriplegic cerebral palsy due to brain injury at the death of his twin several months before they were born. Though he smiles and laughs and has sparkly eyes, he is nonverbal, tube-fed, and is unable to sit up on his own or walk. But you can clearly see from this picture that he is treasured by his family. He has taught all of us wonderful and important things. All of his siblings have served at camps and even had employment with organizations that serve people with disabilities, all because they see the value of individuals with disabilities and have experienced the needs families affected by disabilities firsthand and desire to help. You see, Jonathan and many more like him require 24/7 assistance, much like a high maintenance newborn that continues with high needs for many years. Many families like ours have had few nights of sleep in decades. Our families need breaks like any other family, and we call these breaks respite. However, it is tough to find people who feel comfortable taking care of our children due to their medical and/or behavior challenges. Even family members and close friends are not willing to help out for even an hour. And due to medical bills from massive therapy and doctor copays, if they have health insurance, most of these families can't afford to pay someone to provide a babysitter for their child with disabilities to give them a break. This impacts the siblings, as the parent often has difficulty providing the attention they need and can't even attend their band concerts or basketball games due to accessibility of the facility or behavior outbursts of the sibling with disabilities. And marriages are also impacted in harsh ways, as there is no time to be together due to the care needs of the child, of the sibling with disabilities. So this brings us to the next Policy Council for Children and Families goal. We desire to increase access to respite services for families of children with disabilities to strengthen and support families to remain together. The first recommendation is to reinstate the in-home and family support services to provide respite for children who don't have Medicaid. This program was implemented in the 1980s as a small stipend, no more than $3,600 a year. Many didn't get that much out of general revenue dollars, and the impact was significant. My family was able to utilize these services, which gave me opportunities to build relationships with Jonathan's siblings, which paid off. I know of others who use these funds to care for their children with disabilities so that the parents could have life-saving cancer surgery. But the program wasn't funded by the legislature in 2017. They need to be restored. The next recommendation is that policies be put in place to ensure families have access to non-educational funds for children at risk of residential placement. These funds that were primarily used for respite have been available for many years and are distributed through the local school districts. However, families don't know they exist. In 2018, 29% of the appropriated funds were returned to the state, and in 2019, 73% were returned. So it's important in our recommendations to improve the outreach to families of children at risk for residential placement, and to develop service utilization benchmarks for school districts and education service centers, and to provide technical assistance to school districts on the importance and use of funds in overcoming barriers in the delivery of these services, and to increase the funds available statewide. Next slide. The next recommendation is to amend the home and community-based waivers to allow an additional 30 to 60 days of respite per year. This would allow caregivers to get needed surgeries or get critically needed breaks for longer than is allowed at this time. The attendant care services that make up the majority of these waiver budgets do not pay for overnight stays. Respite does. This would not require additional funds, as they would just shift attendant hours to respite hours. So it's a pretty no-brainer and not a difficult thing, but we need you to help with it. The next recommendation asks to increase access to respite for families of children in the Youth Empowerment Services waiver, the YES waiver, for enhancing the provider base to make it a viable resource for families. The Texas YES waiver supports children under 19 with serious mental health conditions to live in their homes and families. One of the key services requested by families of children with mental health conditions is respite, as you would imagine. Families report difficulty in getting respite services needed through the YES waiver unless the family recruits and hires the respite provider. This is often difficult for families who are already so stressed and distanced from family and friends due to the support needs of the child. So this recommendation is very important. Lastly, the council recommends that HCS, the Home and Community-Based Services, host families be allowed to access respite services outside of the daily rate assigned to the family to promote placement stability for the child. The host home benefit in the HCS waiver allows for children who cannot live at home with their families to live with another family who is paid a daily rate to care for them and ensure all of their needs, including their permanency needs, are met. This keeps them in a home setting and not in an institution. Currently, host families caring for children do not have access to respite outside the daily rate. When the model rates of the HCS host home benefit were designed years ago, the model anticipated a family needing 30 days of respite. Initially, 30 days of respite was built into the rate, but has not been updated to reflect the current market. Many HCS host families do not obtain respite because the rate is insufficient to pay someone to assist in the home. Additionally, 30 days is insufficient for families caring for a child who has significant behavioral support needs and might need sleep or might exhibit extreme aggression. An additional 30 to 60 days of respite provided outside of the host home rate would help to ensure that host families have access to respite needed and to ensure families do not bounce from family to family. The HCS host family placement is likely to break down if the families caring for children with significant behavioral support needs do not get additional supports. Bottom line is that respite is critically important for families like mine. Thank you so much for considering assisting and addressing these very important recommendations. This is Dylan, a child who's been on the MDCP waiver waiting list since July of 2017, and that's a short wait. I mean, most families wait for a very long time, 10 to 12 years to get these resources. Thank you very much.
Good afternoon. My name is Keisha Sobers Butler, and I am a Doctor of Nursing Practice candidate, RN, who also happens to be the mom of an amazing 18-year-old who suffers with VACTERL syndrome, who currently receives the services through the Medically Dependent Children Program, Waiver. I represent the Policy Council for Children and Families as a family representative. So today I want to speak a little bit in terms of acronyms on some things. The first is discussing the continuity of the member care emergency response. This is called the ComSER plan, and a little bit of history on it. The continuity of member care emergency response plan was developed to incorporate a disaster response and actions of managed care organizations in result of an emergency. When I say managed care organizations, I probably will refer to them as MCOs. It was established as an annual requirement that is proactive and used to assess for risk of each unique service area in which an MCO operates. Our recommendations are enhancements based on our current experiences with the public health emergency COVID, as well as my personal experience as an executive director of a Texas Medicaid managed care organization. We recognize that our experiences have worked extremely well in this time frame, but we also recognize that there have been some opportunities that we're presenting today. So our recommendations include that the ComSER plan adapt a process for a pandemic or identified public health emergency. Currently, it does have a plan in place for environmental and natural disasters for that MCO requirement. We're also going to ask that the ComSER plan add additional information regarding extensions and flexibilities as that relates to authorizations for our families and maybe even an eligibility component as a suggestion. We want that new ComSER plan to include the following: to have the managed care organizations do exercises with their providers and their network that serve medically fragile populations, such as nursing facilities. We would like for those exercises to be designed to engage families, to engage the managed care organizational staff, and other relevant stakeholders to work together to manage the response of a hypothetical incident. We would also like that managed care organizations make adjustments to plans upon identifying those needs through those exercises, upon experiencing a disaster or learning new information about outside resources. We want membership to include key stakeholders to work together to manage the response to a hypothetical incident. We would also like disaster-specific assessments developed by HHSC, the Health and Human Services Commission for the managed care organization, to complete during a pandemic or disaster, such as adding COVID assessments or whatever that public health emergency is at that time, assessments around social determinants of health and our environmental assessments. Next slide, please. We're proposing additional elements such as the COMSA plan addressing defined templates for which the managed care organization will report members impacted and services delivered during disaster and publish the report indicators. We do have from time to time received from that MCO perspective reports, but sometimes they change as they're being developed in the middle. So what we're asking is for a more proactive approach. In doing that, we ask that the MCLs develop a team, perhaps of dedicated people. These are only suggestions of roles that can include a pandemic response coordinator, someone that can act as the point of contact for a health plan, a person who can answer questions or refer to that point of contact within each department. In today's world, we do have some of these things outlined, so we're not starting from scratch, but what these are just enhancement or recommendations. We're also asking about the MCO education and training for member engagement so that we can have persons who will provide that member education regarding a pandemic as we've been in the middle of, or can produce short videos on different topics. We've seen this done, but not with the standard. We also are suggesting elements around network resources where the MCO may be able to identify a network representative who can serve in and out of network providers during an emergency, but before that emergency is happening, more proactive. Next slide, please. This is Angela. She is a young girl who happens to have Down syndrome, who has been on multiple waiting lists since 2008. Next slide. So the second policy issue I'm going to speak about is communication. This issue relates to ensuring that proactive communication and involvement for our Medicaid families continue, especially during a public health emergency. For families eligible for Medicaid and CHIP services, it is essential that families receive clear, concise, and deliberate communication that is quick and accessible. Some of the challenges that affect communication with consumers include the basis of that eligibility determination, how consumers can use their coverage, the next steps for consumers, and even legal rights and responsibilities. Studies indicate many of the challenges are based on timeliness of that information received and literacy to process information. As I've mentioned before, as a mom of a child who has the medically dependent children program services, information is very accessible to me because of my career. But for that mom that may not have those types of supports at their right hand, this is what we're offering for those families to identify best practices to communicate and educate families, providers, and MCOs. And that can be through standardization of websites, more involvement from the member advisory committees within those managed care organizations, getting more with communication between the service coordination and service management departments, incorporating texting that gives mom a little text message that says your benefits are continuing, and our recorded messages where they can get information on the status of their benefits. Next slide, please. And then lastly, we want to continue with requiring the managed care organizations to develop plans, to develop with children and their families a communication support plan that can go with them to the hospital in the event they are separated by their primary caregiver. The plan should be person-centered, include things like communication techniques of that individual, the likes and the dislikes of that individual, the way that person prefers to be cared for, and of course, all the necessities such as their diagnoses, their medications, food allergies, food preferences of the individual, and of course, the emergency contact. Our recommendation includes that the managed care organization communication to members be consistent through their website, through their committees, and through their service coordinators to make certain that our families are always included. And I will hand off to Maggie. Thank you.
Thank you, Keisha. So this is my daughter Olivia with her twin sister Keegan enjoying the snow day. They were sad that it wasn't actually on a school day, so they got to miss school. But I'm going to talk about proposed changes to the MDCP waiver during the COVID-19 pandemic. For those of you that don't know, the MDCP waiver is one of the oldest waivers in Texas and has provided support to thousands of Texas children. MDCP provides respite care, flexible family support services, minor home modifications, adaptive aids, transition assistance services, employment assistance, supported employment, and financial management services through Star Kids Managed Care Organization. So it's a very comprehensive program. So we are recommending that plans of care that expire during the pandemic be extended by 12 months as allowed in the Texas CMS approved Appendix K. This allows HHSC to authorize extensions without face-to-face visits, which can lead to unnecessary COVID exposure. We also ask that the waiver be amended to allow for a reserved capacity of nursing facility diversion waivers for children with medical fragility that are at risk of facility admission and do not require a nursing facility stay. Texas does not currently have a mechanism to allow children with extensive medical complexity to be diverted from a nursing facility. Current protocol is for the child to be on a waiting list, often for years, or placed in a nursing home. Our goal is to always try to keep the child at home with their family with appropriate support. Finally, we're asking to allow initial and annual MDCP assessments be conducted through telehealth to limit unnecessarily COVID exposure. While face-to-face visits may be optimal, telehealth assessments offer a safe alternative for the child, family, and MDC personnel. With that, I'm going to turn it over to Lisa Brody to review our last recommendation. And this is the Macy family. Chris is actually online today, and this is the Macy family. Lisa?
Hi, thank you. So we all know the impacts of this pandemic. We've all been impacted by the way we communicate, the way we learn, the way we work, and telemedicine has allowed medical services to be delivered safely to families in a time of social distancing. So we would like to make recommendations to expand telemedicine during COVID-19 pandemic. The recommendation would be to identify technology that is user-friendly across Texas. And instead of authorizing telemedicine benefits in 30 to 60-day increments, which has been what has happened throughout the pandemic, just extending by 30 days, consider 6 months to 1 year to allow for services so that goals related to long-term therapy needs continue without interruption. And such benefits that individuals may be receiving would be therapies, physical, speech, occupational therapy, MD visits, and music therapy, I'm sure recreational therapy, and behavioral health services. We'd like to further recommend that a telehealth benefit for children be authorized with home health intermittent nursing services in addition to therapy and behavioral health. An example would be assessing a patient's status through parent questioning, patient observation, troubleshooting, parent, family, caregiver teaching. Telemedicine provides an avenue for that to happen without a physical visit that can be done through telehealth. And we'd recommend that the telehealth become a standard alternative for Medicaid and other state programs during times of a pandemic or a disaster for all non-essential home visits where hands-on interventions are not absolutely needed. And then next, we'd like to further recommend that families have access to technology and equipment and add diagnostic equipment funding for telemedicine at home. In the pandemic, we've seen school districts have provided technology to families, broadband, Wi-Fi, tablets, laptops. We would like to ensure that the quality of equipment is varied, especially in rural areas, and just to ensure that families that have medically fragile children will have access to telemedicine. And we need to consider language barriers with access to telemedicine, such as software for translation or translation services. And then we'd further like to recommend allowing funding for telehealth technology, remote patient monitoring, and diagnostics for community partnerships with school nurse and other healthcare professionals that can utilize these diagnostic tools, such as checking temperatures and other diagnostic readings to be transmitted. I kind of went through those quickly just for sake of time so that we'd be available to answer any questions. Maggie?
Thank you, Lisa. In conclusion, we would all just like to thank you again for attending today. We know your time is valuable and you're being asked to govern in extraordinary times. These children and families face repeated and significant obstacles to receiving timely and quality-based care, especially in a time of crisis. You can reduce the amount of time they spend on wait list, reduce the amount of time spent coordinating care across multiple providers and vendors, and improve access to medical and other support systems meant to meet the varied, complex needs of this vulnerable population. But most importantly, you will help these children grow up in homes with family support, with their family and support, so they can reach their fullest potential in life. Thank you for attending today. I'm gonna open up the floor to the chat, any chat box questions. Kate, do we have any questions in the chat box?
So far, no questions other than emailing the presentation, which Chris has been going through and sending that out to everybody. And then once we have uploaded this video to YouTube, we'll share that as well. But those were the only two questions I've seen so far. So if there aren't any other questions, I think that's it. Let's see. No. So Mary Kate asked, can you expand on what you thought the best solution / recommendation was to reducing MDCP wait lists?
Elizabeth, would you mind tackling this one? You're on mute, Elizabeth.
That would help to take it off. The one recommendation, which I think is a really easy one to reduce the waiting list, is to offer everyone who is currently on the waiting list who has SSI or Medicaid access to that waiver with no wait. HHSC and the legislature did this for adults with disabilities when they rolled out the STAR Plus waiver. And so there is no wait for an adult who has SSI and meets a nursing facility level of care to get the STAR Plus waiver. So we're asking that the same process be used for children. If that is done, then there will only be a handful of kids still on the waiting list. There'll only be like 575 who rise to the top and will be eligible, who would need funding. So if we implemented everybody on SSI gets it automatically, then the number that we have to fund is reduced tremendously. And it's doable.
Thank you, Elizabeth.
Any other questions? I guess if people have questions after this presentation, what's the best way for them to reach out and ask those?
I think it would be through me on the initial emails. It was sent from my email account, so please feel free to email me, and then I will also send out an email once we get the YouTube video up. So it's maggie.mclean@yahoo.com. And if you wanted to put that in the chat box, that would be fine. Or actually, I could type that in there. All right. Well, again, thank you so much, everyone, for your attendance today. We greatly appreciate it. Please reach out with questions, comments, and concerns. And to our council members who are present today, thank you for taking time out of your busy schedules as well to present our recommendations. I truly appreciate all your help. This has been a Herculean effort during these interesting times.
Thank you, Maggie. We appreciate your leadership. Have a great day.
You too.